Welcome to everyone. My name is Jen Carlo. I'm with Patient Choices Vermont, and we're delighted that so many of you have joined us on this Tuesday evening. I'd like to introduce two people before we go too far. This is Amy Bruce. She's the Executive Director of Patient Choices Vermont.
Thanks so much for joining us.
This is Mandi Zucker. She is the Executive Director of End of Life Choices New York and our featured speaker for the evening. Welcome, Mandi. We have really enjoyed working with Mandi these many months since the governor signed that bill and especially in getting ready for this presentation. New York and Vermont share a long border, so we look forward to being partners well into the future. A couple of housekeeping items. We are recording tonight. So as I said before, if you would prefer to stay off camera, that's fine for your privacy. Generally, we'll be sharing screens, so we won't be able to see too many participant images, but please do whatever makes you comfortable. And please go ahead if you're comfortable and put your name in the chat and where you're zooming in from so that we know who's here. We're going to start with a brief presentation from me about about Vermont's law and process, and then Mandi is going to take over. So we're going to encourage folks to put as many questions in the chat as you have. We'll take them probably at the end of my presentation and then at the end of Mandi's, unless there's something that feels immediate and urgent, but we want to make sure that we're answering everyone's questions. So please feel free to put anything that you would like in the chat while we're talking. Okay. So, a little bit about Act 39 and medical aid and dying in Vermont. Patient Choices Vermont is a nonprofit. We're funded by donations and grants. As you can imagine, we do not get state or federal funding. We were founded in 2002 and successfully advocated for over 10 years to pass Vermont's Patient Choice at End of Life Law, Act 39 in 2013. Since then, we've worked as an organization to safeguard and improve the law. And things changed pretty significantly in Vermont in 2023 when Act 39 was amended to allow non-residents to access MAID in Vermont. That makes us one of only two states in the country that will allow non-residents to come to Vermont and follow the process and access medical aid in dying. It's worth noting that for folks who do that, all of the steps of the process must take place in Vermont with Vermont licensed physicians. But again, that's unusual. It's just Vermont and Oregon that allow that. We also provide education and outreach around medical aid in dying in Act 39. That's why you're here. This is one of our big venues for doing that. And we have a very, very small staff. You're looking at both of them right now, but we are supported by several wonderful volunteers. I promise, I read very, very few slides, but medical aid in dying has a very particular definition. And so this one I do read because there are some elements in here that are important to note. Medical aid in dying allows qualified adults who are terminally ill and who are capable of making their own decisions the option to receive a prescription medication to be self-administered to bring about a peaceful death at the time of the patient's choosing. And all of those significant elements must be present. Medical aid in dying can only be accessed by qualified adults through a very specific process that's laid out under the law. The qualifications to access medical aid in dying in Vermont, and you're going to hear something very similar from Mandi later in the presentation. And we could invite any state or jurisdiction in the United States where medical aid in dying is legal, and you would see pretty much this. The qualifications are very broadly similar. You have to be an adult, of course. You must have a terminal diagnosis and a prognosis of 6 months or less. You must have the mental capacity to make healthcare decisions, and that must be true throughout the process, right up until the time that you ingest the medication. You have to be making an informed and voluntary request, and you have to self-administer the medication. And all of those qualifications must be met in all cases. There are no shortcuts, there are no exceptions. In Vermont, and this is where states can differ a little bit, In Vermont, the process to access medical aid in dying is you need to make two oral requests to your prescribing physician, and those need to be 15 days apart. That's a built-in waiting period. That's one of the safeguards under Vermont's law. You also need to make a written request to the prescribing physician, and it's a form. You can find it easily on our website and on the Vermont Department of Health website. The form has to be witnessed by two unrelated adults who are not on your care team and don't have any interest or benefit in your death. And then you need to have a second physician confirm that you've met the qualifications and you followed the process, and then the prescription can be written. People ask about the day of ingestion, but what we've also found is that people really want more information about it and sometimes are a little bit shy to ask. So we just share the information so that we're being as open as possible. On the day of ingestion, a patient will take two medications for nausea about half an hour before the medical aid in dying medication. The idea is to make sure that the medication gets into your system and stays there. After you confirm again that you wish to ingest, the patient needs to drink the medical aid in dying medication without assistance. Again, that's a very important element in the law that the medication must be self-administered. The medication is a compounded powder and it's mixed with about 2 ounces of clear liquid, usually water or apple juice, to make sure that it's dissolved properly. The patient will fall asleep typically within 5 to 10 minutes after taking the medication and will not awaken again. The time to death can be variable. About 80% of patients will die within 2 hours, although it can be longer. And the prescribing physician should be aware of any red flags or anything that may lead to a longer time until death. Again, the patient is asleep, or unconscious, I should say. The patient is unconscious and will not awaken, but it's best to make sure that family and loved ones in your support team are prepared if it seems like it might take longer. We strongly recommend hospice enrollment for anyone at the end of life, but certainly folks who are accessing medical aid in dying. And if you are enrolled in hospice, typically your death can be pronounced by a hospice nurse if you are under their care. Medical aid in dying is always voluntary. Qualified patients can choose to pursue MAID, but it's always the patient's choice. The patient can stop the process or rescind a request at any time. The patient can go all the way through the process, even have the prescription filled and then not take the medication. The patient can stop the process at any time. It's always voluntary. That's true of healthcare providers as well. There's no physician or nurse or pharmacist who is required to participate in medical aid in dying in any way. Doctors who prescribe MAID medication must inform patients of all of their end-of-life options, MAID, hospice, palliative care, etc. And for those who maybe need a little extra help talking to their doctors about this, we do have resources on our website and at our in-person presentations with sample questions and ways to frame the conversation and other resources that will help you have those challenging conversations. And again, it's so important that we put it on 2 slides in a row. We really strongly recommend hospice enrollment. A couple of resources that you will find on the Patient Choices Vermont website. And we're going to talk a little bit more about the resources of both organizations at the end of the presentation. We do have a helpline that's primarily a web form. There is a voicemail that's sometimes people use, but almost all of our inquiries come in through a form on our website. And we get about 1,000 of them a year, people writing from all over asking for information about the process and the law in Vermont and about medical aid in dying. And we have 4 wonderful, dedicated volunteers who work very hard, usually a week at a time, to respond really very quickly through email to those requests. And we found that it can be a great comfort to people just to make contact with people or with another person with a name who can answer some questions and provide links and access to other resources. There's also something in Vermont called the Wayfinder Network. It's an independent and collaborative group. Folks with end-of-life experience, they're doulas, they're retired hospice nurses, case managers, therapists, various professional backgrounds, and they help primarily folks who are coming from out of state, although they do help some in-person, or excuse me, in-state residents as well, with lodging, logistics, locating prescribers, finding a place to ingest, all of the things that can be an additional challenge for folks coming from outside the state. Any questions specifically about Vermont before we move on to Mandy's part of the presentation?
I'm not sure if it's an actual question, but someone with a diagnosis of ALS said the 6 month requirement is still so foggy. That prognosis can be more difficult for people with different kinds of conditions. So it's important to stay in touch with your doctor. Generally, if you're at the point where you would be eligible for hospice, that because hospice also has that same 6 month requirement, you would be at about that time eligible for medical aid in dying as well. But if there's a more specific question, please go ahead and add that. But I don't see any other questions.
Okay, great. Please continue to put questions in the chat, and we'll handle the rest when Mandy's done with her slides. So, Mandy, take it away.
Thank you for having me. So end of life choices, sort of similar to Patient Choices Vermont, had worked on passing this law for over 10 years. We actually were the ones that initiated the bill and asked Assemblymember Amy Paulin to co-lead, to co-sponsor the bill back in, I think it was 2015. So we've been working on it for a long time. I'll say New York and Vermont are both very lucky that they had organizations like that, because many other states in this country didn't have organizations like ours until after the bill has been passed. And then there's lots of catch up and all of this work that we've been doing for really years, and certainly past 6 months or so, to make sure that we're ready, which wasn't done in many other states. So I think probably Vermont, and certainly I feel New York is in a better position than we would have been otherwise, where people are just sort of scrambling to find information like this. So I feel very glad that we exist. I'm not going to get into too much of the history, because probably people don't care so much about how we got here, but are more interested in what we're doing now. So if people have questions, I'm certainly happy to answer that. But in February, Governor Hochul signed the act into law. What she did at that point was say there's a 6 month waiting period before the law can be implemented. So that brings us to August 5th, which is fine. Actually, it was a good thing, because it gave us 6 months to get ready, and certainly gave the Department of Health 6 months to get together some of the reporting requirements. And we've been working with major hospital systems and hospices and clinicians from around the state who have a ton of questions and want to be ready on August 5th. So the reality is many of them still haven't reached out, don't have information yet. And that's okay, because we're not going anywhere. So people, as they become more aware that this law exists, they will continue to reach out, and we will continue to provide education and support to both professionals and lay people. So one of the things that we have done in the past 6 months is partnered with the Academy for Aid in Dying Medicine. They are a national clinical organization. They really support the clinicians who are interested in providing care. So when I say clinicians, I don't just mean doctors. I mean chaplains and social workers and end-of-life doulas and nurses and pharmacists, really anybody that is working with people who are considering aid in dying. And they have some incredible education and resources on their website, most of which are free, unless you want like some continuing education credit or something which you can pay for. But I highly recommend that people go check it out. I see Natalie is here. Natalie, I'm going to just ask you to put their website in the chat so people have that as well. And then what we've been doing is also working with uh, individual clinicians and interested people, lawyers and advocates from around the state. So we've been meeting every 2 weeks, I think since before February, I can't remember, that we are providing all of the outreach and awareness that we can and answering questions in a regular sort of forum so that people feel like they are ready, and people are bringing up really good questions that some of their patients are asking, or that their family members are asking, and it's been very helpful to us so that we can do some research and make sure that we have answers to questions. So one of the other things that we've done as far as implementation goes, we have put together, it's about a 20-page guide to specific to New York. We're not really trying to share it as a PDF because we will be updating it regularly, but I will say by the end of this week, it will be on our website. So if you are interested in this guide, you can go to our website and you can download it. It's just that we may update it, especially in the next few weeks as we are, learning more with the implementation. The other thing that we've been doing is collecting names of clinicians that are interested in providing aid and dying care. This is a confidential list. So people keep calling and saying, can I have a list of all the doctors in New York that are providing aid and dying? We are not providing that list for many, many different reasons, but one of which is really that we are trying to provide this for patients. We don't want to give a list to patients who are going through a lot to have to call 10 doctors and leave messages and repeat their story 12 times. And then the doctor says, sorry, I can't take you. I don't take your insurance. So we are collecting all of that information from patients, and then we are reaching out to doctors or other clinicians saying, this is the situation. Are you available? Are you able to assist this patient? If they say yes, we then give them the patient's name, and then they're able to call that patient. I will be completely honest, the list specifically for doctors at the moment is small. And some of that is related to their institutions that they're working with, who have policies that they cannot be the prescribing doctors. I expect that the list will continue to grow, but I think there may be a little frustration on August 5th when people call and say, I need a doctor in, specifically in this town. We may not have that information yet. Medical aid and dying, as I said, becomes effective on August 5th. Generally speaking, the requirements are the same in every state, not just Vermont and New York, but you must be 18. You have to have a terminal diagnosis with a prognosis of 6 months or less. You must be mentally capable of making the decision at the time of ingestion, so throughout the whole process. You have to be able to self-ingest the medication, and you must choose this option voluntarily without coercion. However, there are a few differences. So those are like the basic requirements, and I believe every single state in this country has those requirements. In New York, there's a few little nuances that I want to make sure that you are aware of. So a patient must first make an oral request to your attending or your prescribing physician. In the law, it says that that must be in person, although there is a waiver if that is very burdensome. So the first oral request must be in person, generally speaking. In New York, unlike any other state in this country, Governor Hochul added a safeguard that there must also be some kind of a recording, either audio or video. My guess will be that it will be almost 100% audio. That will be stored in a patient's medical record that says that you are choosing medical aid and dying of your own free will without coercion. So it is just another safeguard that Governor Hochul requested. And as I said, that visit must be in person. So after all of that is done, and the doctor informs the patient about all of their options, then they will refer to a consulting doctor. So this is the second doctor, who must confirm that the patient is eligible by all of the criteria that we've already gone over. There is no waiting period. So in some states, and Vermont already mentioned that they have a waiting period, there is not a waiting period here. So in theory, you could go to one doctor in the morning and one doctor in the afternoon. If any of you get your medical care in New York City, I think you'll understand that that's almost impossible to get appointments that quickly, but that's, in theory, there is no waiting period. I think partly because there is sort of a built-in waiting period to get appointments. That second appointment, though, does not have to be in person. So that makes it a little bit easier to meet with doctors then. They must also inform patients that a mental health professional must also evaluate the patient to confirm their capacity to make decisions. So this is different than in Vermont. Actually, Hawaii and New York are the only two states that require some kind of a capacity evaluation. The reality is it's already happened in every other state. So you've already met with two doctors. The likelihood that a patient is going to go to a psychiatrist or a psychologist for this capacity evaluation and be deemed unable to make decisions is very low because there are two doctors that have already seen the patient. They're not going to refer them to a mental health evaluation if they're not able to make those decisions, right? So those doctors are already evaluating, and in every other state except for Hawaii and New York, they've already made that decision, and those states feel very comfortable making, allowing those doctors to make that decision. So again, the mental health assessment does not have to be in person, which is good, especially in rural areas of New York. So that evaluation must be completed by either a psychiatrist, a psychologist, or a neurologist. That was the governor's amendments. We did not actually have that in the law. That was not something we wanted at all, the capacity evaluation. So this was an amendment that Governor Hochul added as a safeguard. And she determined that it needs to be a psychiatrist, a psychologist, a neurologist. It cannot be a licensed clinical social worker. It cannot be a nurse practitioner, anyone else. Those are the three professions that are allowed to do this assessment at this point. And basically, the assessment is to determine a few things. That the patient understands what their diagnosis and their prognosis is. They understand what medical aid in dying is. They understand that medical aid in dying will hasten their death, and that they are choosing that voluntarily. It is not a mental health evaluation to say you have depression, you are not eligible. That is not true. And in every state, a mental health diagnosis does not exclude you from using the law. It is not the reason you can be looking for medical aid in dying. So you can have depression. You won't qualify for medical aid in dying unless you also have a terminal cancer with a prognosis of 6 months or less, right? So a mental illness does not exclude you, but it doesn't automatically include you either, right? And this evaluation is not to determine mental health. It's there to determine your capacity of understanding and ability to make this decision. Okay, so if your attending or prescribing physician determines that you qualify for medical aid in dying based on all of the criteria that we've gone over, the patient is then required to write a written request, just like in Vermont. And again, you are consenting to self-administration for the purpose of ending your life. And again, it's voluntary without coercion. You must have two witnesses. They may not be family members, your healthcare providers, or anybody that will benefit from your death, meaning anybody that is named in your will. Okay, I think I said all of that. So they can't be your power of attorney or your healthcare proxy. I didn't mention that, but after all of that is done, your attending or prescribing doctor can then write a prescription that you can get at a compounding pharmacy. So these are not drugs that you're going to pick up at CVS or Walgreens. These are very specialized, usually like independent pharmacies. We have about 5 identified already in New York, so which is really good because those drugs can be sent by courier. We may have some volunteers that can pick up the drugs for you. So 5 pharmacies to start is actually very good. Now, Vermont has this waiting period between requests. We do not have a 15-day waiting period between requests. What the governor did do is add a 5-day waiting period once the medication is ordered. So the doctor will place the order to the pharmacy. Now you must wait 5 days in order to pick it up. And that was her attempt to say, okay, we're very close to the end here. Take a few days and think about this decision. There is a waiver if you are likely to die within those 5 days, but generally speaking, you will wait 5 days to pick up the prescription. And it's very important to understand that because many people think you're going to call the doctor, you're going to get all of these, appointments done very quickly. Then you're going to go to the pharmacy, pick up your medication like the next day, and you're not. Medical aid in dying is really not a crisis intervention. This is a very well thought out, planned process, and no one is going to be able to access it, very, very quickly. So you will have to wait for the medication for about 5 days. And then you can pick it up. Again, the patient must self-administer the medication. And as Jen said very clearly, you are under no obligation to administer it at all, even if you purchase it. I will say that the medications are not cheap and they are not covered by insurance. So we really don't recommend, for many reasons, picking them up unless you're planning on taking them fairly soon. As you can imagine, these are incredibly potent, lethal drugs, not things you want hanging around the house. So we really don't recommend that you pick them up and keep them in your home for longer than you need to. So I'm just going to summarize quickly some of the similarities and differences. So similarities are that the basic qualifications are the same, and that is actually the same for every state in this country. You must meet with both a prescribing doctor and a consulting doctor that confirms your diagnosis and your prognosis. All steps of the process must take place within the state. So even in Vermont, if you are a non-resident, you must be in Vermont through the whole process, right? Which actually makes it kind of difficult for people because you have a 15-day waiting period. So you go to one doctor, you have to go to the next doctor 15 days later. So you have to have somewhere to be or be well enough to travel back and forth. In New York, you have to be in New York. So even though the visits are through telehealth, you have to be in New York when you are meeting with any of the doctors, even if it's remote. And then the entire process is voluntary, and there is no point at all through the process that you can't say, I've changed my mind. In fact, what I always say when people say, I'm doing medical aid in dying, or that's my plan, you're not doing it until you do it. You are considering it all along the process. You're considering all of your options because the reality is things can change. So your capacity to make decisions can change at any time. Your ability to self-ingest medications can change at any time. So to only have one plan is probably not a great idea, which is why we really encourage you and your doctors to make sure that you are talking about the whole host of options. And Jen said before that, she strongly encourages hospice participation, as do we. Hospice provides incredible care. And if your situation changes, which likely it will throughout the process, whether or not you're able to use medical aid in dying, you want to have really good care. and be comfortable. So we really encourage hospice and to know what all of your options are, to stay educated about all of your end of life choices. Okay, a couple of key differences. Vermont does not have a residency requirement. New York does. We do require a capacity evaluation by a mental health practitioner. Vermont does not. Vermont has this 15-day waiting period between doctor visits. We do not have a 15-day waiting period between doctor visits. So, like I said, in theory, you could go to one doctor in the morning and another doctor in the afternoon. We do have a waiting period of 5 days once the prescription is written at the pharmacy. And these are some additional resources for us and for Patient Choices Vermont. So I highly encourage you to look at our website. We have a newsletter. It actually is going out tomorrow morning. It goes out every other Wednesday, where we provide as much information as we can about what's happening, what we're doing as far as implementation. So I encourage you to sign up for the newsletter and stay informed. And obviously, we are available as much as we can. I think we have the same staffing, which is interesting because New York is a much larger state and much more populated than Vermont. I see Natalie on the call. Sorry, Natalie, I see you taking a sip of something. But Natalie is our full-time program director. I would say, it was interesting that Jen said before that they get about 1,000 calls a year. We probably get that also. We expect it to exponentially increase once the law is implemented. And at the moment, it's the two of us. So I will say, please be patient with us. We are in the process of hiring a part-time patient coordinator, really specifically to answer those calls so that we can be more responsive. But it's a big state and there's a lot of questions, and we're small. We are also basically funded by individual donations. So we're doing the best we can with the resources that we have. And I hope that we'll be able to help as many of you as possible. And I also hope that you're as patient with us as we're trying to be with ourselves, because it's hard for us too. We feel like we want to make sure we're getting to everyone.
Hi, thank you. Hi, nice to see you again, Mandi and Natalie. I have three, they're short and they might be two in the weeds. So if they're two in the weeds, you can say not the right forum. But I'm curious if there's been an instance where a patient ingested the medication and didn't die, and what happens in that case?
I am unaware of a situation like that.
Okay.
Oh, go ahead.
No, no.
That's one of the first questions I asked when I took this job, so that's not a weird question at all. Everybody wants to know that, and no, especially under the current formulation, there's no known cases of that.
Okay.
The difference, I'll just say what we have been told, and I think Jen talked about that a bit, is the timing that it takes from when you take the medication until the time of death. So most patients will die within 2 hours. There have been cases that it extends 24 hours. And that is something that patients are often not prepared for. And they're like, what's happening? Is this not working? It's been 6 hours. So that happens. And it's a great thing to talk to your doctor about. As doctors are more and more familiar with this, there's some ways to tell. This may look like a longer time to death. Sometimes it's related to age and weight and the mode of ingestion, but that can vary.
Okay. Considering that obviously these medications are lethal, if a patient fills the prescription and brings it home and doesn't end up using it, what is the safeguard to retrieve that med?
So within that guide that we're providing, there are instructions for safe disposal. As we said, most patients are in hospice. So, most patients have some pretty significant drugs already in their home, and hospice does a great job of helping families to dispose of medications. It's also why, as I mentioned, we really encourage you not to pick up the medication unless you're going to be using it.
Right.
There's just no reason to have that in your home, and it's expensive. So I don't know if Patient Choices Vermont has a process
The
or.
the pharmacists that provide the medications in Vermont also provide instructions to the families on how to dispose of the medication if they choose not to use it, whether that's returning it to the pharmacy for safe disposal or other methods.
Okay. And this is my
That
last
part
question.
actually is not that uncommon. There are, a significant number of people that will pick up the medication and don't end up taking it. So it is important to know how to dispose of it.
And this is my last question. If you ask your attending physician, basically, does now that this will become a law in August 5th, is your attending physician required to help you if you ask for help? Or can they decline to assist you?
They can absolutely decline.
Okay.
What they are supposed to do is refer you to another provider. It may mean that they're referring you to us because, as I mentioned, there's not a ton of providers yet. So they might not know where to refer you, but they are absolutely, no one is required to participate if they are uncomfortable for whatever reason. Yeah.
And I'll add that
Thank you.
because someone asked about the Veterans Administration, and as a federal agency, the VA is not allowed to participate in medical aid in dying, and in some VA settings that can include a policy that does not allow them to make a referral. So that's why organizations like Patient Choices Vermont and End of Life Choices New York are so important, because if the doctor that you're working with, whether that's a VA doctor or a doctor at a federally qualified health center, is under a policy that does not allow them to discuss medical aid in dying with you, then you can call us and to get more information, whether that's simply education and about what medical aid in dying is and who qualifies, or to try to get a referral to a prescribing physician.
And I'll just say that it's one of the reasons that I'm so glad to be here tonight, because we really need to be doing as many presentations like this as possible. There are so many. I was sharing the story before. My cousin is a doctor in New Jersey, where the law has been legal for 5 or 6 years. About a year ago, I mentioned something about medical aid in dying, and she had no idea that it exists in New Jersey. And she's a oncology radiologist who diagnoses people with breast cancer mostly. And she didn't know it exists. So there is so much work that has to happen to make sure not just that clinicians know about it, but that regular lay people know about it. Because the more people that go to their doctor and say, do you know about this? Or I'm interested in this. If that happens to the same doctor a couple times, they're going to say, maybe I need to learn something. So we really encourage you, first of all, to speak to your doctor, but also if you're involved in an organization, if you have a book club, if you're in a senior center or any kind of an organization, a disease specific organization, we would love to come and speak to the constituents or the members there.
Ditto for Vermont. If you have suggestions about an organization or a place that would welcome a presentation, we're happy to come. Please put that in the chat or reach out to me via email. I put my email in the chat as well. We share that.
Yes.
Madeline.
Yes. To start, I'd like to say thank you to every one of you, because this has been a most informative and important session. I have two questions, please. I thought I understood Jen saying early on that once the patient takes the medication, they are unconscious. And yet just now it was said, if somebody doesn't die right away and it takes more than an hour or two, they'll be concerned. Well, if they're unconscious, how could they be concerned?
Yeah,
The
it's the
patient.
family.
Yeah, the patient won't be
Oh,
concerned. The
oh,
patient is
okay.
unconscious, but if there's any reason for the prescribing physician to anticipate that perhaps the death process may take a little bit longer, it's good to prepare the family and the support folks for that so that they can anticipate that.
Very good. Okay, thank you. And the other that I see is up on the chat, it says it takes at least 6 to 9 months to get an appointment with a mental health provider. If you have to proceed with this, if you, when you have 6 months to live, is there a chance that you won't get a provider if it's going to take that long to
It
get
won't
that?
take that long.
Oh,
We have a list of providers that want to help. So it might take a regular person 6 to 9 months to get an appointment with a psychiatrist. If you're just calling and saying, I'd like to schedule an appointment, I hope it doesn't take that long. I'm sure it does in some parts of New York. But we have relationships with people. So if you are struggling to find a psychiatrist or a psychologist, just reach out to us and we have providers that will meet with people.
perfect. Thank you so much.
Absolutely. Good questions.
There were a couple questions about how the provider would evaluate mental capacity. And again, this is not a mental health assessment in either in Vermont with the prescribing physician or in New York with the mental health professional. It's simply a doctor determining that you understand your disease process, you understand what will happen if you choose medical aid in dying, and you understand what all of your other options are. So it's much more like informed consent for other medical procedures.
Mhm.
If someone has a disease that is limiting their verbal communication, if they have an alternative way that they communicate, and the doctor will engage with that alternative mode of communication. And so people that have aphasia or speech difficulty would still potentially be able to qualify. Um, the more complicated scenario that was shared in the chat around someone receiving a dementia diagnosis simply because of a communication difficulty, that's a little bit it's a little complicated to try to break down in this setting. Um, so I'm happy, Jen or I, happy to answer that over email or a call at another time. And then I think, Mandy, people were asking about the cost of the prescription in New York, if you have a sense right already of what that will be.
So first, I just want to also say about the capacity evaluations. If you are asking because you are a clinician, if you're a psychiatrist or a psychologist, and you're asking about what the evaluation will entail, again, I encourage you to go to the Academy's website. They have a pathway for psychiatrists. You can watch the video for free to learn exactly what the capacity evaluation should look like. So I just wanted to say that. So as far as costs go, I spoke to someone actually today who said that they thought it was going to cost around $1,200 for the medications. I have heard less than that. Today I heard 1,200. I have heard somewhere between 500 and 1,000. I've spoken to a pharmacist actually, and they said to me, do patients understand that it's going to cost a lot of money? And I said, yeah. And they said, like, it's going to be like somewhere between $500 and $1,000. They're not used to having patients have to pay that kind of money for prescriptions. But they said it is, clearly incredible doses of some of the medication that some of us take right now, right? But it is 100 times that amount. So, of course, the medications are going to cost more. We are concerned about the pricing only because some people are not going to have the kind of money to be able to pay for that. There are some services out there that will help with cost. And we're looking into that as well, seeing if there's some way we can help on a limited basis with some of the costs associated with this process. So if you are thinking to yourself, I want this and I don't have $1,000 for medication and a couple $100 for a capacity evaluation, please reach out to us. I am not promising anything, but please reach out to us because we are looking into how we can provide assistance for folks. We have several donors who have said, just call me if you have somebody that really can't afford this. Like that's the way that they want to help. So, again, I'm not making promises, but we are very aware that cost can be a barrier.
I have a question.
Mhm.
As a physician, if I was not participating in MAID, but I had a patient that I knew was terminal, and they requested my assessment, I would be obligated to send that in as the first certifying physician. That would be my obligation, I would think. I don't think a physician could refuse to do that.
I don't think, I'm not a physician myself, but I assume that as a physician, you want to be able to provide really good quality care. And if you can't provide something for your patients, you would say to them, you need to see someone else who can provide that kind of care, right? We don't recommend plastic surgeons provide medical aid in dying, even though there's nothing in the law that says that they can't, right? But we want it to be physicians who are capable and comfortable and educated about this process. And if you feel like it is not something that you are comfortable, qualified, or even just like opposed to, we don't want you to provide it. What we want you to do, just like you would do with any other procedure, any other request, I don't know what kind of doctor you are, but let's say you're a cardiologist and a patient comes to you and you find out that they have cancer, you're going to say you should speak to an oncologist. And that's really what we want to make sure you're doing.
I'm a family physician and palliative care physician.
Oh, okay.
I would certainly be involved, but if I had that information and the patient requested that information, I would have to send that form to the patient or to another doctor. I don't see I could ethically not provide that information. It's just my opinion. But
Yeah.
yeah.
Well, we like your ethics.
Right.
And I appreciate that. And it does, then because physicians are often don't share publicly that they're going to engage with medical aid in dying and either serve as a prescribing physician or a consulting physician, it really is incumbent on physicians to talk to their colleagues and find out which of their colleagues are participating if they themselves will not be. So you can make that referral. I appreciate that very much.
One more question. If the patient is already involved with hospice and enrolled in hospice, has been getting hospice medication, and then decides to go through the process and is certified, will hospice pay for the medication?
No.
No.
Okay, I don't think so. All right, thank you.
I see a
Sharon?
question about residency. How long must you live in New York to be a resident? There is not a set determination. Really, there's not a definition of what a resident is in New York. Like many states, some states have a very clear definition of what a resident is. New York does not. So I'm going to leave it at that, but there is no set that you have to live in New York for 6 months or 2 years or anything like that.
Yeah. Sharon,
I just sent it in the chat.
can the hospice physician be one of the referring physicians?
So are you asking in New York or in Vermont?
In New York.
So referring, I'm not sure what that means. Referring to a doctor or like the prescribing or attending doctor?
I guess what I'm asking is that if a person has we've had several questions where people have insinuated that their regular doctor or their attending physician would not be in agreement with this. And I guess my question is, if that person is already in hospice or if they've been moved into hospice care, can that hospice doctor be the person who does that referring?
So in theory, the answer is yes. In reality, many hospices have said, at least for now, that they will not be the attending doctor. that they will be supportive of patients. They will not abandon patients in any way, and they will, hospices have wide range of policies saying like we will allow our nurses and our clinicians to be part of the process, but we will not prescribe the medication. Some of them say we'll be there through the whole process, but we're going to leave the room when the patient ingests. There's a ton of there's a lot of nuance. Many of the hospices at this point have said we will not be the prescribing doctor,
Okay, thank you.
which is part of the access issue at this point. I'll just say that out loud because, that's where many of our patients are, and they don't have a doctor outside of the facility. So it's the hospices are saying, yes, we will be supportive, but finding a doctor is going to be the challenge at this point.
Right.
So.
And I'll share one of the one of the reasons for that, and there are several, but one of the reasons for that is that there is a federal law that restricts the use of Medicare or Medicaid funds for medical aid in dying. And hospices primarily receive payment through Medicare. And so while it is possible, the the way that they have to work their reimbursement to stay in compliance with that federal law is difficult. So that's one of the reasons that many hospices, even if they are not a religious-based hospice and don't have ethical or religious uh, practices that would restrict them from participating, the funding is really a challenge for them.
Amy, there's also a question in the chat about long-term care facilities, patients attempting to use the MAID process in a long-term care facility. Do you want to kind of continue with that?
Sure. So, long-term care facilities, so facilities that provide health care as opposed to assisted living, where people are often living more independently. Skilled nursing facilities can cannot they have the choice of participating or not. And so while I can't answer the question specifically if a patient has ever attempted to use MAID in a long-term care facility, because we don't govern those facilities, so I don't know what examples there might be out there. They can opt out of medical aid in dying. If there are inpatient hospice facilities, like we have one in Vermont, they also can restrict people taking the medication within the facility. Often, what those facilities will do for those patients is transfer them back to a home setting. So, hospice will transfer them back to a home setting and continue to provide home-based care as opposed to acute care within their facility, and then the patient can use the medication within the home setting.
Any other questions? We're coming up on 8 o'clock, but we're happy to take some more if people have them. Should also add that Mandi and I are happy to stay on a little bit if folks have questions that for whatever reason you're not comfortable sharing with the entire group, or again, you can reach out at any time through our email. I put ours in the chat, and as I said, there is a web form, a helpline web form on the Patient Choices website that we monitor continually. And if you want to ask us a question through that, we will respond in that way. So please feel free to do that.
And I just want to thank everybody that worked so hard for so long in New York to get this law passed for their residents. While Vermont has been very happy to allow people to come from any state if they qualify to use medical aid in dying here in Vermont, and many people from New York have, it is an arduous process, as you can imagine, to travel and often 2 or 3 times to make that trip to be able to access it away from home. And generally, people want to pass at home, surrounded by their friends and family. So we're so happy that New York is on the cusp of being able to do this.
I agree.
Just one final note, there's a comment, I think there will be concern with equity in obtaining this option. And I just want to add that we echo that. We're always concerned about, ways to increase equity and access to medical aid in dying. And as you can see, there are some barriers, there are some challenges, and so that's of continuing concern, I think, to everyone who works in this space. And there are no easy answers, but I just wanted to acknowledge the concern and say that we absolutely share it.
Yes, us too. I mean, I feel like it's one of the things that keeps me up at night because I do not want it to be a, rich, educated option. Um, and it is certainly a worry, and that's financial is only one of the barriers, but it is certainly one of them that we're working on.
Yeah,
Like I
and
said,
there are, very dedicated physicians that will offer this at a very low cost to to patients. They understand that without insurance coverage, can be a really challenging thing, and they know people are paying for the medication out of pocket, at the very least, in addition to other costs. So it is important for people to speak up and let us know your challenges, let the physicians that you're talking to know what limitations are, because often the people that are engaging in this really they understand that this is a difficult care to obtain, and they're very dedicated to supporting people's options and want to be there for people. So they often will be quite flexible with the fees that they charge.
Thank you all so much for coming tonight. You will receive a follow-up email with a link to the video, which will be on our website. You can watch it again. You can share the link with folks. And we hope to see you again at another Exit Matters. Next month's topic is the speaker from Compassion and Choices talking about having challenging conversations with your family about end-of-life choices and medical aid in dying. And that should be also a very, very informative, good presentation. So please join us. We'd love to see you again.